Welcome back to EM Rapid. Now we will discuss about neck of femur fracture. So here we can see the figure of the femur, the proximal end of femur. We can see the head here, then the femoral neck and femoral neck here. So if at all there is a fracture line in the head, that will be a head fracture. Then below the head we will be seeing the neck of femur fracture. So the capsule of the hip joint will extend up to the base of the neck. So if the neck of the femur gets fractured, it will be an intracapsular fracture. And if at all there is a fracture in the intertrochanteric region, so we can see the greater trochanter and the lesser trochanter. And if there is a fracture between the trochanters, that is an intertrochanteric fracture, it will be an extracapsular fracture. And if it is below the trochanters, that is called as a subtrochanteric fracture, that is also an extracapsular fracture. So fracture neck of femur is an intracapsular fracture, and because of this fracture, the blood supply to the femoral head will be affected. So usually the femoral head will get its blood supply through the femoral neck. So the blood supply is from distal end to the proximal end. So if there is a fracture of the neck of femur, the blood supply to the head will get affected. So what are the risk factors for fracture neck of femur? So it is usually seen in elderly because of osteoporosis, and it can be seen because of some pathological fractures, some bone diseases, or because of malignancy, or in young adults it is seen secondary to a very severe injury. Presentation in elderly and all, sometimes the patient may present to our ER walking. There might be a little pain to the groin region or the inner thigh region. But sometimes, depending on the displacement of the fracture, patient will have more worsening of symptoms. So they might complain of inability to move the limb or bear weight secondary to a trivial fall. And since the pain is in the thigh region, we will not be able to see any swelling as such. So swelling might be absent. And in some patients, if at all it is not much displaced, and if the patient doesn't have much symptoms, this fracture might be missed for at least days or weeks. So symptoms worsens as the displacement of the fracture worsens. And on examination, we will be seeing, here we can see a figure. In that left lower limb, there is a neck of femur fracture. So we can see the limb is externally rotated and the patella is facing outwards, and there is shortening of the limb and it is abducted outside, and there might be tenderness in the groin region, and when we are attempting for hip movements, it will be painful and patient will not be able to do a straight leg raising. And when we take the X-ray, we can see a break in the cortex in the neck. So first we will have to observe the neck and the head. There will be a break in the continuity of the cortex, and the femur might be externally rotated. So external rotation of the femur can be appreciated by looking the lesser trochanter. So if the lesser trochanter is becoming more prominent, that means the femur has rotated externally. So in this figure on the upper side, we can see on the right side, there is a break in the cortex in the neck and the femur is externally rotated. So the lesser trochanter on the right side is more prominent than the left side. And there will be overriding of the greater trochanter. So the greater trochanter will be at a higher level as compared to the normal side. And there will be a break in the trabecular stream. So trabecular streams cannot be well appreciated in this X-ray. If at all there is fracture, there can be break in the trabecular stream depending on the classification of fracture. And there will be a break in the Shenden's line. So what is Shenden's line? So in the lower part, we can see the Shenden's line. It is a smooth curvilinear line along the superior border of the obturator foramen and the medial aspect of the femoral metaphyse. So that will be broken in case of a neck of femur fracture. If at all we cannot find a fracture in X-ray, occult fractures can be diagnosed in CT scan. So we'll move on to the classifications. So in the first figure, we can see the neck of femur and the intertrochanteric region. So in the neck itself, we can divide the neck into subcapital, that is immediately below the head, that part of the neck is called subcapital. If it is in the center of the neck, it is transcervical, and if it is basal part just above the intertrochanteric region, that is a basal. So that is the anatomical classification of the neck of femur fracture. And depending on the line of fracture or the degree of the line of fracture, we can divide the neck of femur fracture based on Powell's classification. So we will be checking the degree of the fracture from the transverse line. So as the degree of fracture increases, the prognosis will be poor. And the blood supply to the femoral head will be affected more. So as the degree increases, it is showing a worse outcome. Next is the Gardens classification. So Gardens classification, it is of 4 types or 4 stages. Stage 1 means there will not be a fracture as such. The fracture might be incomplete. Head might be little bit tilted, and we can only see that there is some tilt in the trabecular stream, and it is called as an impacted or an abducted fracture. Stage 2 is there is a fracture which is complete, but it is undisplaced. There is a break in the trabecular system. The trabecular stream is broken, but it is still aligned properly. Now, stage 3. Stage 3, there is a fracture which is complete and it is partially displaced. So, when we look at the trabecular stream, it is seen broken and displaced. Next is stage 4. It is also a complete fracture like stage 3, but it is fully displaced. In stage 3, it is partially displaced, but in stage 4, it is fully displaced. And we can see the trabecular stream is also not aligned, but we can see the trabecular stream between the head and acetabulum will be normally aligned. So these are the 4 stages. Stage 1, we can see the trabecula is just bending only. Stage 2, there is a fracture, but it is totally undisplaced. The trabecula has broken, but it is aligned somewhat in the same direction itself. There is no loss of that. There is no loss or bending of the stream, but it is break is definitely there. Stage 3, we can see all the it is a complete fracture with partial displacement, and there is no trabecular alignment, and the trabecula has broken. Stage 4, it is a complete fracture with a complete displacement, but the trabecula between the head and the acetabulum is continued. So in the ED, in this discussion, we will be mainly focusing on the ED management of the fracture neck of femur. So in the ED, we will be mainly focusing on the pain management. So systemic analgesic should be given according to the WHO pain ladder. Paracetamol, NSAID and opioids can be given. And we know that in elderly, NSAIDs and opioids will have its own adverse effects like renal failure, respiratory depression and all. And procedural sedation, if at all required, can be tried for just before plastering or anything. And specifically to the hip region or to the fracture neck of femur and all, we will have 2 specific blocks, that is the femoral nerve block and the fascia iliaca block. So we will discuss about that now. So the femoral nerve block. So we can block the femoral nerve in the same region itself. If we are giving some more local anesthetic, we can block the obturator and the lateral cutaneous nerve also. So it is a 3-in-1 block. So this femoral nerve block is used for proximal femur fracture and hip fractures in elderly. And as I told, it is a 3-in-1 block. So if at all we want the obturator and the lateral cutaneous nerve also to be anesthetized, we can give it after giving the local anesthetic injection, we can give a distal pressure so that the local anesthetic will proceed somewhat in the cephaloid direction, so that the obturator nerve and the lateral cutaneous nerve will also get anesthetized. And we will have to make sure that we will assess the patient's distal neurovascular status before giving the block. So in a patient with the fracture, any type of fracture, we should assess the neurovascular status before giving blocks or analgesic to the patient. Otherwise, after that, we will not be able to assess that correctly. So, if you are planning to give a femoral nerve block, First, how to position the patient. So make the patient in a supine position. Then if it is an obese patient, just keep a pillow beneath the hip and just retract the lower abdomen superiorly. Then the femoral nerve, usually it is positioned as shown in this figure. It is positioned as vein, artery, nerve from medial to lateral. So nerve will be the lateral most. So the femoral nerve is positioned lateral and deeper to the femoral artery. So the femoral nerve block will provide anesthesia to the anterior thigh and the medial part of the leg, which is supplied by the femoral nerve. So how to do this? So technique wise, we can do either with a peripheral nerve stimulator if at all it is available in the ED, or using ultrasound guidance. So actually this femoral nerve is a superficial nerve. It is just 2 to 3 centimeter below the skin. We can locate the femoral artery on the affected side with the non-injecting hand and slightly then lateral to that artery we will have to inject it, and we will have to direct the syringe somewhat cephaloid, and we will have to raise a wheel of anesthetic in the subcutaneous plane and at the level of the inguinal crease and 1 centimeter lateral to the femoral artery. If we have a peripheral nerve stimulator, it will confirm the position of the needle by showing the contraction in the quadriceps muscle and patellar movement. If the sartorius muscle is contracting, the patella will not move. So the needle should be repositioned and it should be directed more laterally. Sometimes this sartorius muscle itself can mimic as a quadriceps contraction, but the patella will not move. Patella will move only if the quadriceps contracts. So that's how we recognize we are in the correct position or not. And if we are doing it without a peripheral nerve stimulator, then we will be confirming the position when the patient is reporting paresthesia over the anterior thigh. So once if we are pricking onto the nerve, the patient will complain of paresthesia over the anterior thigh. So we will have to pull the needle slightly outward so that we can anesthetize the perineural space. So inject 20 ml of anesthetic solution to that perineural space. If the paresthesia cannot be elicited, then the needle should be withdrawn and redirected somewhat 10 to 15 degrees more laterally from the femoral artery, and we will again assess for the paresthesia. Alternatively, a blind attempt can be done by injecting a larger quantity, that is somewhat between 30 to 40 ml of local anesthetic can be injected to that area, assuming that the patient will get anesthetized. So before injecting any local anesthesia, make sure that we are not puncturing into the artery, because we know that the vein is very close to the artery. So to avoid that, always aspirate and see. And if at all we feel that there is some resistance felt, we do not inject into that, because we might be in the femoral nerve. So don't inject into the nerve. We are planning to inject only to the perineural space. So as I told, it is a 3-in-1 block, and if at all we want to anesthetize the lateral cutaneous nerve and the obturator nerve, give a distal pressure. So first inject 20 ml of anesthetic solution and then give a distal pressure below the injection, below the femoral nerve for at least 5 minutes, so that the local anesthesia will go to the go cephaloid, and it will anesthetize the obturator nerve and the lateral cutaneous nerve. Next, we will talk about the fascia iliaca compartment block or the lateral femoral cutaneous nerve block. So it does not depend on the local anesthetic near an individual nerve, but instead it will act in that facial plane. So here we don't want a nerve stimulator as such. We can just do it under ultrasound guidance or using anatomical approach. Here also patient is positioned in the supine position. So we can see the inguinal ligament here. We can see the obturator nerve, which is most medial one, the femoral nerve, which is somewhat in the middle, and the lateral cutaneous nerve, we can see it as lateral. So we will be anesthetizing the lateral part so that that entire plane will get anesthetized. So in order to give the fascia iliaca compartment block under USG guidance, we should first draw a line from the anterior superior iliac spine and the pubic tubercle, and we will divide it into three. And the ultrasound probe is placed transversely to the leg at the junction between the middle and the lateral third to identify the fascia lata, the iliacus muscle, and the fascia iliaca. So we will be identifying both the fascias and the iliacus muscle, which is lying below this both fascias. So the needle is introduced slowly after negative aspiration, and 30 ml of local anesthetic is given in 5 ml, 5 ml increments. Make sure that we are aspirating each time before giving the injection. So the local anesthetic will spread medially and laterally and will anesthetize the medial and lateral part of the thigh. So here we can see the image. We can see the fascia lata and fascia iliaca. So when we are puncturing, we will be puncturing both the fascias and we will be going into the iliacus muscle. So just above the iliacus muscle, we will be giving the local anesthetic as shown in this pictorial representation. We will be giving below this both fascias. So while we are inserting through these two fascias, we will be getting two pop-like feeling. So the direction on down I will just mention now. So we will be drawing a line between the anterior superior iliac spine and the pubic tubercle, and it is trisected as I told before. And between the lateral third and the middle third, we will be drawing a perpendicular line 2 cm caudally, and the needle is inserted and directed cephaloid at 45 degrees. And we will get two pop like feeling is felt, and that means we are passing through the fascia lata and fascia iliaca. Then after negative aspiration, 30 ml of local anesthetic is injected with 30 ml increments. Make sure that we are aspirating before injecting the local anesthetic. Now, perineural catheter fascia iliaca block. So that is to give a continuous infusion of local anesthetic to that area. So the technique is we will be placing a catheter in that area, and we will be giving slow continuous infusion of a local anesthetic like bupivacaine. We will be giving 8 to 10 ml per hour. So we will, that person will be getting a continuous infusion of local anesthetic. Now we will discuss about the treatment of neck of femur fracture. So the treatment will depend on the patient's age, how the neck of femur fracture is displaced and all. So in the ED, we will be mainly managing the pain and all. And traction wise, skeletal traction or skin traction is not much indicated in neck of femur fracture because that can worsen the femoral head's blood supply. So we will be mainly managing the pain. And the definitive management depends on the blood supply. So we all know that the blood supply to the head will get cut off. So depending on how better we can save the head of the femur, we will be deciding on the treatment. So decision regarding the timing and the type of operative intervention will depend on the patient's age, activity level and the severity of fracture. And sometimes if the patient is not ambulatory, or if the patient's operative risk is very much high because of the comorbidities, sometimes conservative management is also considered. So this is broadly a flowchart telling which all will be the management of neck of femur fracture. If it is an undisplaced fracture, sometimes conservative management will be done, and sometimes screwing might be done in undisplaced fracture. And if it is a displaced fracture, depending on the age, if the age is less than 60 years and if the closed reduction can be done under X-ray control, and if closed reduction is successful, we can just screw the fracture. Or if it is not possible, if closed reduction fails, we will be doing open reduction and screw fixation. And in elderly more than 60 years, they might require a hip replacement. So depending on the hip, or if there is any pre-existing arthritis and all, this patient might require an acetabulum, a new acetabulum and a femoral head and neck. So in such patients, they will have to undergo a total hip replacement, or otherwise If the if the patient's acetabulum is healthy enough, these patients might require only a partial hip replacement or a hemiarthroplasty. So now we will discuss about the complications. Complication, 30 to 40%. Non-union is the main complication. So it is because of the inadequate healing. Even with a proper internal fixation, it might be because of the poor blood supply to the head of the femur. And the patient might complain of pain and inability to bear weight. Another complication is the avascular necrosis of the head. The viability of the femoral head after a neck of femur fracture usually depends on the blood supply through the ligamentum teres, which is connecting the acetabulum and the head. So if that is also affected, then this patient will go into avascular necrosis of the head of femur. And this will cause non-union of the fracture. So diagnosis of avascular necrosis is best done by MRI. And if this continues, this patient might develop osteoarthritis. Another complication is osteoarthritis itself. It can be because of avascular necrosis or the union of a faulty alignment. So patient might complain of pain and stiffness of the joint. And the treatment of these also will depend upon the functional requirement of the patient and the age. Now we'll just discuss about the intertrochanteric fracture. Intertrochanteric fracture is a differential diagnosis of neck of femur fracture, but we know that neck of femur fracture is intra-articular and intertrochanteric fracture is extra-articular. So intertrochanteric fracture is extra-articular fracture. It is between the greater and the lesser trochanter, and it is usually seen in elderly and in osteoporosis, those people, and there will be a marked deformity. It will not be like neck of femur fracture. The deformity, the external rotation, the abduction, and the pain will be more severe in intertrochanteric fracture. And this fracture can be easily visualized in standard AP views and in lateral views. And the complications like avascular necrosis and non-union are not very common with intertrochanteric fracture because the neck and the head is paired, so the blood supply to those areas will not be affected. So these complications are rare. So this is a table to differentiate both the fractures. So the pain, the swelling, the ecchymosis, and the presentation will be more severe in case of intertrochanteric fracture. And the complication is main complication with neck of femur fracture is non-union, and in intertrochanteric fracture the main complication is malunion. So this is the X-ray film of the intertrochanteric fracture. Here we can see the head and the neck is appearing normal, and from the trochanteric region, when we are looking down, there is a obvious deformity seen. And the distal femur is somewhat directed posteriorly. So this is intertrochanteric fracture. So we mainly discuss about the neck of femur fracture and one of the close differential diagnosis, that is the intertrochanteric fracture. And we discussed how to manage the pain in this condition. And just we grossly went through the operative management also. So I hope you have understood this. Thank you.